So good afternoon again. Thank you all so much for joining us this afternoon. My name is Christina Newport, and I am a program manager for the U.S. program at AmeriCares. We're going to go ahead and get started. It's about 2:35, so without further ado, I will jump right in. We're really pleased to have this opportunity to connect with all of you and share information with you today about the ECHO initiative that we're launching for free and charitable clinics in Illinois on hypertension. As you know from our communications, we are now accepting applications for this new initiative. And so today, what we wanted to be able to do was give you a comprehensive overview of the initiative and to also answer any questions you might have as you start to think through and work on your application. So just a few logistics before we get started. We'd love to hear from all of you and what clinics you're calling in from today. So on the left-hand side of your screen, you'll see a little chat feature. So if you could just chat into us the clinics that you're calling in from, we'd love to see that and to hear from you. We're going to ask that everyone keep their line muted during the presentation portion, just in the beginning. And again, you can mute your phone by pushing *6. And you can also mute your computer speakers by clicking on the microphone icon on the top of the screen if you're connected to the audio through your computer. During the presentation, though, if you do have a question or if you want to send us a note or a comment, you can do so through the chat box on the left-hand side of the screen or through the Q&A box on the right-hand side of the screen. All of that will come to the presenters, and we'll see that coming in from you. And we'll do our best to answer your questions, but we'll definitely try to leave some time at the end of the presentation to open up the line for Q&A. So I thought we would just start by doing some introductions on our end to introduce all of you to the different collaborators that have come together for this exciting initiative and opportunity in Illinois. I've introduced myself already, but I also wanted to take a moment to introduce you to my colleague, Lindsay O'Brien, Associate Director of U.S. Programs at AmeriCares. Lindsay's on vacation this week, so she couldn't be with us, but she will be playing an active role by facilitating the implementation of this initiative over the next few months because I am going out on maternity leave relatively shortly. I also wanted to just take a moment to give a brief overview of AmeriCares for those of you who may not be familiar with our work. AmeriCares is a global health and emergency response organization, and our work centers around improving the health and lives of those in need, both in times of disaster and also through the ongoing partnerships that we have with organizations throughout the world. Here in the U.S., our work is generously supported by the GE Foundation. We are the largest provider of donated medicines, vaccines, and medical supplies to the U.S. healthcare safety net. And we work by partnering with safety net facilities to expand access to care and to enhance treatment for the low-income and underinsured populations that they serve. We have more than 800 partners in over 2,100 delivery sites throughout the country in all 50 states. And I think one of the key elements that truly sets us apart from the work that we do are the capacity building programs that we offer, like the ECHO initiative you'll be learning about today, which we couldn't be more excited about. So with that, I'm going to kick it over to you, Leslie, from the Illinois Association of Free and Charitable Clinics, and you probably need no introduction to this group, but I thought I'd give you a moment to introduce yourself.
Thank you, Christina. Hi, everybody. Can everybody hear me? I don't even know if I would hear you if you said yes. But Christina, can you hear me?
Yes, I can.
I can hear you.
I'm going to take that as a yes. Okay.
I can hear you too.
Hi. Okay, cool. Sorry. This is Leslie. I'm the Executive Director of the Illinois Association of Free and Charitable Clinics. Although right now I am calling you from Camelback Resort in beautiful Phoenix, Arizona, because that's how excited I am about this project. You know about the association. We exist to support and strengthen our sector in the state of Illinois. And this is just a huge and exciting milestone for us. So thank you, everybody, for participating in this webinar.
And hi, everyone. This is Julie Darnell. I am in the School of Public Health at the University of Illinois at Chicago and have the pleasure of overseeing the evaluation activities in this initiative.
And this is Tamara Hamlish from the University of Chicago, ECHO Chicago. I'm the executive director for ECHO Chicago, and unfortunately, or unfortunately for us, and fortunately for him, Daniel Johnson is on vacation, celebrating his birthday on the beach in Michigan, and Dr. Backrus is, I can't keep track of him, but he's not here. He's out of the country. So I'm the representative from ECHO Chicago, and I won't say too much about us because there's slides a little bit later, and I know there's a couple of people on the call who are already familiar with us, but we're a telehealth program that was founded 5 years ago, and a replication of the project in New Mexico, and their project focused on connecting rural health centers, and ours up till now has really focused on connecting urban health centers with subspecialists to increase knowledge of providers and the best practices in the community setting.
Thanks so much, Tamara. So here's our outline and agenda for the webinar today, and really what we hope to cover in the hour of time that we have with all of you. So we want to just spend a little time providing an overview of the program and the initiative. We'll talk a little bit in more depth about the ECHO model, which some of you may already be familiar with, as Tamara mentioned, in ECHO Chicago. But we'll also spend some time talking about the clinic eligibility criteria that we outlined in the RFP. Julie will talk about the evaluation and research component of this work, and then we'll review the details on submitting an application, what the timeline looks like in terms of participation in the program, and then of course we hope to leave some time at the end for questions and hope to address those for you as well. So just to set the stage, I wanted to talk a little bit about the chronic disease care program at AmeriCares. So we developed this overarching framework called the chronic disease care program for some of the capacity building work that we would be doing. And the chronic disease care program is really designed to build the readiness and capacity of free and charitable clinics around chronic disease prevention and management. So under this framework and through the implementation of demonstration programs, we're aiming to enhance the quality of care and also improve outcomes for patients by providing training, resources, and support on implementing evidence-based interventions in free and charitable clinics. And our ultimate goal or outcome is really to showcase what free and charitable clinics can do as a group and the quality of care they provide to their patients. We also want to be able to gain a better understanding of how programs like these work in free and charitable clinics. And so to that end, we'll be doing an evaluation or evaluating our efforts as we go and really taking a look at the impact that we can have through research. What we hope to be able to do is share our findings with the larger sector to serve as a model for adoption and also to elevate the work of free and charitable clinics as a whole. So under this CDCP, we now have 2 demonstration programs, this ECHO initiative you're learning about today, and we also are implementing a national initiative on prediabetes that's already underway, which involves implementing the CDC's National Diabetes Prevention Program. And just like the support of the U.S. program, both of these initiatives and programs are generously supported by the GE Foundation, and we're just very fortunate to have their support in this work. So, I know I'm speaking here to the choir, and as you're all aware, hypertension is a common diagnosis among patients that seek care in free and charitable clinics in all medical settings. In fact, it's one of the most common chronic medical conditions. We know that about 30% of adults in the U.S. have hypertension, which is categorized by having high blood pressure, and is also a major risk factor for other significant health issues. So by focusing on hypertension, we knew we would be addressing one of the key issues you see in your clinic and with your patient population. So The bullets you see here on this slide are really just designed to give you a quick overview of some of the key elements of the overarching initiative and how it will work, and we'll kind of delve a little bit deeper into each of these as we walk through the slides. So under this initiative, we'll be selecting 7 free and charitable clinics in Illinois to participate in the Echo Chicago Hypertension Clinic through an application and proposal process. We'll be providing $10,000 grants to each of the participating clinics that are selected for participation for their involvement in the initiative and really to cover the costs of staff time that it takes to participate. Each of the clinics will be responsible for selecting a minimum of 2 providers to participate in the Echo Hypertension Clinic, as well as identifying an administrator to oversee the program implementation, and also potentially staff involved in patient education to participate as needed or required. So the Echo Chicago Hypertension Clinic involves 12 weekly consecutive sessions. These are 1-hour video conferencing sessions that your providers will participate in with Dr. Bakris, the hypertension specialist at Echo Chicago. And these sessions will begin in February. As part of participation in this work, each site will be responsible for data collection and reporting, which we will support with training. We'll be developing a web-based database to report data into for the clinics, and then also providing training on that. And then we just ask that, there's a commitment from the clinics who are applying for the initiative to participate in ongoing initiative-related activities. So, on-site visits, the webinars that we offer, and of course, committing to participating in all 12 of the sessions with Echo Chicago. And I should mention here too that the providers that participate in the Echo Chicago Clinic for hypertension will receive and can receive CMEs for their participation. So with that, I'm going to turn it over to Tamara to talk in greater detail about the Echo model and also specifically about Echo Chicago and their hypertension clinic.
So the ECHO stands for Extension of Community Health Outcomes, and it was developed at the University of New Mexico. I should know this off the top of my head, but I think it was probably in 2003, maybe 2005. It's been around for a while. And it was designed by a hepatologist in order to, he noticed that he was seeing a lot of patients arrive at the University of New Mexico Medical Center with advanced stage liver disease, and he wanted to see if there was a way that he could get them better care before they came to the University of New Mexico, and built the program, this telehealth program, initially around hepatitis C, and it's now grown to many different diseases. The goal is through case-based sort of virtual rounding, so there's a short, each telehealth session has a short didactic followed by case-based discussions, and the goal is that through those case-based discussions you get practical learning in how to manage cases that can be managed in the primary care setting, and that you don't have to worry about whether or not you can refer and how long it's going to take and what's going to happen to the patient. I am just finished preparing a poster that I'm presenting next week at the National Association of Community Health Centers and describing how many buses it takes for someone to get from a clinic on the south side to the University of Chicago Medical Center. So the challenges are huge when someone can actually get an appointment, and that's what this is designed to overcome. So we use web-based video conferencing technology, so it requires minimal bandwidth, and we use plug-and-play technology. You can use a laptop, you can use a cell phone, although we don't encourage it because it's really hard to get a good picture of yourself. And the goal is that you're interactive on these, that you're engaged, that it's a two-way conversation. It's not designed as a webinar to tell you what the guidelines are, but it's really about addressing the challenges of implementing those guidelines in the setting where you work. In the meantime, it's a group of, in this case, 7 clinics that would be on the session, and people would get to know each other. You're treating similar populations or facing similar challenges. And so it really is designed to sort of provide peer conversation as well as an expert walking you through the guidelines. And Dr. Bacris is actually has been on the guidelines committee for many years. He's the head of our hypertension center, and he's internationally known. He travels. I mean, he will log on from India one week and from Turkey another week. He's extremely knowledgeable and extremely responsive in being able to talk about how to treat in a variety of settings. It's one of his biggest areas of research and expertise. So the goal is that by the end of 10 sessions, you will feel, the providers at your site will feel very comfortable treating hypertension, resistant hypertension, or patients who are particularly challenging, not necessarily because of the type of hypertension, but it could be because of lifestyle changes that have to be made, because of any of the variety of things. Those are all discussed. I would say probably 30 to 40% of the sessions are spent talking about the non-clinical aspects of patient engagement and patient communication, and talking about how to talk to people about staying adherent to medication and dietary changes and lifestyle changes. The clinic, this particular clinic, was our very first clinic at the University of Chicago. We went to the Southside community and asked them what disease area they felt would be the best for the pilot. We were the second replication project in the United States of the ECHO model by about 2 days. And we went to the sites and we asked them what they felt was going to be the most important disease area for them. And they came back and we said, hepatitis C, there's this model and we've got the curriculum, it's all worked out. And they said, no, it's hypertension. It's resistant hypertension. Those are the patients who have complications from disease progression. It's really hard to get them into specialists, and we feel really helpless in trying to treat them. We need help with that, and that was how that clinic was born. It's been running steadily for every 6 months. We start a new clinic for the past 5 years, and we've done small studies. We haven't been able to publish them because of the numbers. That we're still working with a small sample size because we're collecting data through case presentations, not from chart review, although we're starting a chart review coming up in the next month or so to actually look at blood pressure data. But for the data that we have from the cases that were presented and discussed, we're getting the same rates of blood pressure control as they do in a subspecialty clinic. So we feel like that's a very successful outcomes. We've published research on the providers, and that providers feel like this is beneficial to their practice. It's interesting, it's engaging, and that it's a really great way to learn. So the things that are covered in the series, as it says in the session, so it's not just the clinical guidelines, but making sure that you're getting the right blood pressure readings, making sure that you're talking to the patient about adherence to medications. We had a provider in one of our very first cohorts who was listening to this and went back and said, we're always telling people not to eat salt, but we don't tell them all the places where salt is hidden. And then she created this wonderful little handout, which then was shared with all the people who participated in that ECHO session about how to talk to people about where salt is hidden in their diet, because a lot of people just don't know those kinds of things. So that's sort of the general overview of the ECHO model and ECHO Chicago. ECHO Chicago has 5 other disease areas. We're expanding to 2 more disease areas in the next year. We've had some pre-clinics participate in other disease areas, and we're really, really excited about this. This is actually born out of a conversation that we had at the annual meeting last year for the Illinois Association of Free and Charitable Clinics, and we're just really, really excited about trying to make this model work for free clinics.
Hi there, this is Leslie. I'm going to jump in and tell you all about the clinic eligibility criteria. Obviously, you need to be a free or charitable clinic in Illinois. We do ask that the participants in this ECHO project be both a member of the Free Clinic, the Illinois Association of Free Clinics, Free and Charitable Clinics, as well as a partner of AmeriCares. And information about both of those, being a member with the association and being a partner of AmeriCares, are available on each of our respective websites. It has to be a clinic that provides essential services, regardless of the patient's ability to pay. It has to be a clinic that is open and providing medical care at least 20 hours a week. It has to be a clinic that provides ongoing chronic disease management. There has to be an ability and willingness to schedule patients for visits on monthly and weekly bases. You have to have broadband capacity to participate in video conference sessions. Don't get scared about this. If you're, able to tap into this webinar right now, chances are you're perfectly fine in terms of the technical capacity. The clinics that will be accepted to participate in this program have to have EMR. So all the hair pulling and hassle that you went through to get electronic medical record systems up, it's going to pay off because you need that to apply for this. There has to be a commitment to report de-identified patient data, obviously patient data with the names removed. We need a commitment from participating clinics to have at least 2 providers participate in all of these ECHO sessions. There's 12 one-hour sessions, same day, same time, on a weekly basis. But we want 2 providers from each site to participate. We also need a commitment from administrative staff to oversee the initiative implementation as well as data collection. And a commitment from whoever's doing patient education to participate in the initiative. We can talk a little bit more about that later. Let me finish this list here. Obviously, we're looking for leadership engagement. That's engagement throughout the clinic, that everybody's really excited about this and really committed to it. We want clinics that are ready, willing, and eager to participate in all initiative-related activities. And of course, we need the application by August 31st. You may be looking at this list and thinking, wow, this is really complicated, or at least there's some really strong minimum thresholds of capacity for clinics to participate. And you're right. Julie Darnell, our researcher on this project, has really looked at this initiative from all angles. And in order for us to really have a chance at figuring out how the ECHO initiative can effectively impact free and charitable clinics, we need to have a kind of clinic that has this minimum capacity to participate. Because not only is this an amazing opportunity for clinics to learn and to build their base of knowledge and increase or improve patient health, this is all going to be studied. There's going to be a pretty extensive evaluation. Julie will tell you more about that in a minute. But that's why we have this eligibility criteria. I'm ready for the next slide. Do I click through? Do you click through? Here we go. Study, oh, wait a minute. That's the study overview. Benefits to participation. Here we go. This is designed to elevate our work, to showcase what we can do as a group. And there's money. Each of the participating clinics will receive a grant of $10,000. And of course, we'll cover travel and training-related expenses. This is about building the capacity of our clinics. the individuals that actually participate in these weekly meetings will earn CME credits at no additional charge. I should say at no charge. This is an opportunity to participate in a research study. These interventions are standardized and the data will be aggregated. The findings will be targeted for publication in peer-reviewed journal articles. In other words, we're going to be famous. Okay, maybe not, but in any case, there's a high visibility potential on this work. This is an opportunity to highlight contributions to state demonstration and fundraising and advocacy efforts. Let me restate that. Once we do this, depending on what comes out of it, and we think some amazing things will come out of it, we can really talk this up to increase funder awareness of who we are and what we do, as well as advocacy statewide. Is somebody on? No, I thought I heard a voice. Okay. There's formal training, consultation, and feedback from trained hypertension specialists. The knowledge gained can improve care in patients with hypertension. AmeriCares will monitor and support the ongoing implementation, the technical assistance calls, the webinars, the on-site visits. This will foster and cultivate a learning community among participating clinics. There's training on data collection as well as reporting and IRB procedures. And there's improved clinic capacity to report on outcomes. Finally, these skills are transferable to other areas of chronic disease management.
Well, this is Julie. I'm going to echo some of the comments that Leslie has already made, because you notice already that this project isn't simply an opportunity to participate in a very cutting-edge chronic disease management program, but also an opportunity to participate in a research study. And we believe that this is an important step forward for the free and charitable clinic sector, because free and charitable clinics are underrepresented in the research literature, especially concerning matters pertaining to the quality of care. And in addition, while the ECHO model, which is the focus of this project, has proliferated across the country, and as you heard Tamara explain, the hypertensive clinic has been studied in other vulnerable settings. Never before has it been studied systematically in the free and charitable clinic setting. So free and charitable clinics have an important role to play in this initiative toward informing how this model can work in a setting that relies on volunteers to deliver free or very low-cost medical care to uninsured and underserved populations who we know are highly vulnerable and have many complex conditions. So in light of these gaps in our knowledge, our chief aim for this project is to determine the feasibility of implementing the ECHO model in free and charitable clinics. And as part of this exercise, we'll study factors such as the level of interest in participating in the initiative, the attendance among providers in the educational program, the 12-week program that you've already heard about. We'll look at changes in provider knowledge about managing patients with hypertension, changes in provider self-rated competency, and we'll also look at clinic-wide changes in policies and procedures that govern the management of your patients with hypertension. So that's our first aim. Our second aim is to assess the effectiveness of the intervention itself. And we'll do that by examining patients' blood pressure rates and providers' prescribing behavior. We'll examine these trends before, during, and after implementation of the ECHO model. In order to do this, we'll have to collect data. Data will be collected from patients, from providers, and from the clinic as a whole. Our data collection efforts will involve both quantitative data and qualitative data. De-identified patient data, meaning we won't be able to know the identity of the patients who participate, will be abstracted from your electronic medical record systems. will extract information out of your medical records about patients' demographic profile, their visit history, their blood pressure rates, the medications they're taking. All of that kind of data will collect systematically. Turning from patients to providers, information for providers will also be collected from surveys and from participation either in a focus group or in one-on-one individual interviews. We'll be interested in gathering information about providers' practice profile, their knowledge about hypertension, their self-rated competence in managing patients with this condition. We'll be collecting information from the providers at the very beginning of the intervention and at the end so that we can look at any changes over the period. We'll also track their participation in the educational sessions. We'll ask providers also to tell us about their experiences with the program, their satisfaction with the program, and how it impacts their practice, and feedback on ways to improve the delivery of the intervention. So we're collecting information from patients, from providers, and then finally from the clinic itself. We'll be collecting information from administrators and staff through surveys and possibly interviews to understand what this intervention means for the clinic, how it has changed its policies and procedures that govern the management of patients with hypertension. In order to observe any changes in hypertension control and provider behavior, we'll collect data retrospectively 1 year before we implement the intervention. So we'll look back in time, and then prospectively 1 year later after we implement the model. So there'll be a 2-year data collection time period. So that gives you an overview of what we aim to do in the research and the kinds of data that would be needed in order to answer our research questions. So I throw it back to you, Christina.
Thanks, Julie. Really appreciate that. So let's talk a little bit, now that you've gotten the larger overviews, let's talk a little bit about the application process. So all of the materials have been sent via email, but are also accessible on the AmeriCare's Safety Net Center website, which I'll show you a link to in just a second. So the RFP and the other materials that we've provided actually have a link to the application itself. And the link you can see here on this slide, and you can actually hyperlink by clicking directly on the slide within Adobe Connect. So it is a web-based application. What's nice about it is on the first page of the application, you will have the ability to download a PDF version of the application, so you can save it to your computer or print out a copy of it so you can get a sense of the types of questions that we ask throughout the application itself. You also have the ability to save as you go. So once you start the application through this web-based system, you can save and come back later, and it should save all of your previous responses. I will note that on the application, we do ask a question about whether or not your clinic has an electronic medical record or other systems for being able to capture clinical data on patients. If you answer no to this question, the application will kind of kick you out just based off of that eligibility criteria. So I just wanted to make mention of that there, that it'll take you to a page that actually terminates the application for you. So I just wanted to mention that. On the last page of the application, we also ask, there's a letter of agreement that we ask each of the clinics to sign, which just details out their commitment to participation and some of the other elements of the requirements for participating. So you can actually upload your letter of agreement through the online application, or you can send it to us directly through email, which you have, and it could go to me or it can go to Leslie. Either one would be completely fine. And the other thing is that, just to mention, the deadline for the proposals or the applications is August 31st, which is not next Monday, but the following Monday after that. So, if you do have any questions about the application or want to talk to any of us, we're certainly happy to answer your questions today, but also be in touch with you after today's webinar. What I also wanted to highlight was just the timeline of activities related to the initiative, just to give you a sense of some of the key dates that we're looking at. And this is really just a draft, and they're subject to change, but just really to give you a sense of what to expect. And so we hope to be able to turn around our notification to the clinics that have been selected for the initiative by September 4th. Which means that the grant period start date will start shortly after that. In the fall, so through October through December, we really see that as our time to do a lot of the prep, do some trainings to get all of the clinics introduced to each other and comfortable, with each other. I know you guys probably all know each other on some level already, but there'll be some elements of bringing you together and some training that we'll be doing in the fall. What we also hope to do is to hold an in-person kickoff event at the Illinois Association conference in December. So we're still kind of working out the details for what that would look like and when that might be, but we have talked about doing that and using that opportunity to bring all of the clinics who've been selected together. As I had mentioned earlier, the actual Echo Chicago Hypertension Clinic will begin in February. So it will start in February and go through toward the end of April. And then the grant period will continue through April of 2017 to allow for that data collection and reporting period that Julie spoke about. So that just gives you a sense of the timeline of activities, and this is also posted on our website. So the website I keep mentioning is here, so there's a direct link to it here on the slide that you can click to. So we have the RFP, which has the requirements about the eligibility criteria. It has the study information. All of that's included in the RFP. There's a link to the application. That document I just shared with you is also posted on the website, so you can access all of those materials on our website. There are also a few other links here on the slide that may be helpful for you to take a look at or review, which is the Echo Chicago website and then the Project Echo website as well. I also wanted to point out in the bottom right-hand corner of your screen, you'll see a little section that's called Important Documents. So I uploaded a few documents that you can actually download directly from Adobe Connect, which includes a request for proposals, the PDF of the application, the timeline I just shared with you, and then the slides from today's webinar. So all of those materials you can just click on in that bottom right-hand corner and download them to your computer. So with that, I will wrap up the presentation portion and want to make sure to open it up to questions from all of you and give you all a chance to ask any of us anything you want. So in order to unmute your phone, you can push *6, or you can unmute your microphone by clicking on the icon at the top of the screen. You can also chat your questions in through the chat or Q&A boxes on the sides of your screen. And Suzanne, I don't know if you're still with us. It looks like maybe you are. It looks like you also submitted a question, but I'm having trouble accessing it about the de-identified data.
Can you hear me?
I can, yes.
Okay, this is Angie from Normal, and I don't know what happened to Suzanne, but I have a feeling that she and I were kind of thinking the same thing in terms of the de-identified data. Would that be, and then I know when Julie was talking about kind of a web-based data reporting, so would we pull the reports and the information out of our EMR system and then de-identify it and then do data entry into the web-based system? Or would it be a way for us to pull our reports and kind of automatically upload them into your system? And would it be patient-specific, or would we just give kind of summary information on all of our hypertensives?
This is Julie, I'll try to answer your question, Angie. The kind of information that we'll ask clinics to report will be about patients is at the individual level, so that there would be for every individual, it's not aggregated. We would do the aggregation. But the kind of information we would ask you to report would strip out any identifiers. The federal government has a list of, I think, 19 different kinds of information that could potentially identify an individual. And we'll be sure, as part of our process of collecting data, once you've abstracted it from your electronic medical record system, to only input information that would not allow us to identify those patients. I am doubtful that we would have a way to automate the data from your system, since we anticipate that each clinic probably uses a different kind of EMR system, but we'll certainly investigate that once we know the range of EMR systems and think about what automation might be possible. But I think it would be fair for you to expect to have to take information out of your EMR and then re-enter that in the software program that we're using, which is web-based, to report data to us.
Okay, thank you.
Other questions from participants? Yes, we did a really good job of explaining everything. Well, I'm happy to...
For those of you who are on the call, does everybody plan to submit an application, or are you still considering it? We would love to know.
Okay, this is great news. I'm seeing stuff pop up in the chat box. It looks like Angie from Community Healthcare Clinic in Normal, Illinois is submitting for sure, and Laura from Community Health in Chicago is submitting as well. I'm really, really glad to hear that. I hope we get as many qualified, if you will, applications as possible. I realize that the eligibility requirements, simply by the fact that they exist, might exclude some of our clinics, but it still does include a wide number of really wonderful clinics. Julie just asked if everyone on the call is eligible.
Hello?
Hello, I can hear you.
Yeah, okay, this is Sean from Will Grundy. So I do plan on submitting, but I had a question, and it's taking me, I'm on my phone now. At first I was on the webinar, but then I have to leave for an appointment. I have a question about the webinars for the providers. Can you tell me when those webinars take place?
Tamara, have we set that up yet, the day and the time yet that the sessions will take place?
No, I mean, we hold regular sessions right now from 8 to 9 in the morning, and hypertension is usually on Monday mornings. But because this is a special series, we could be flexible. I mean,
Okay.
the only constraint is Dr. Backrus's schedule.
Okay. Because that's my biggest concern is our providers, because all of our providers are volunteers. We have no paid providers, and just ensuring that they're actually able to participate, based on their own schedule. And then also, does it have to be the provider that's like taking on the caseload of patients? Because we have some providers who are on our medical advisory committee, and they actually advise our volunteer providers and kind of set up standards of care for the clinic. Is it possible for like our volunteer medical leaders to participate in the webinars?
Well, this is Julie, and I think my reaction to your question is, of course, the medical advisory providers would be welcome to participate, but I think that we would try to encourage your clinic to get providers who are actually seeing patients also involved, because the research project is really two-pronged. One, to determine whether or not it's feasible to carry out this model in a volunteer setting. And one of your question, I think, anticipates a big question for us. When you're dealing with volunteer providers and not staff providers, does this kind of model even work? But the second aim is meant to get beyond the question of feasibility and whether or not it has an impact on practice. And so there, I think it would become important for us to be able to have the providers who participate actually have a panel of patients so that we could look at the blood pressure rates and look at prescribing practices for those providers who have benefited from the educational intervention.
Okay. And one more question: the education component, does that have to be the provider, or can it be our nurses that provide that education? Because we have on site, it varies between 30 and 40 volunteer providers, and so their frequency, they may come, once a week or once a month or once every 6 months, and so that all of our patients have, there's a consistency in the type of care. I would like my nurses to take the lead on this. So can the education come from the nurses?
Well, we aren't restricting the providers to physician providers, but it's somebody who is clinically responsible for the clinical management of the patient. So if that is a nurse practitioner, certainly it would be appropriate for a nurse practitioner to be the provider who participates, but it's somebody who oversees that patient care.
Okay. Okay, that makes sense.
I don't know, Tamara, if you have anything to add with regard to the qualifications of the providers who could stand to benefit from attending the sessions.
I mean, I think that the most important thing is that it's case-based discussion. So um, it it needs to be someone who understands the clinical side at a medical provider level of the case and can engage in conversation at that level. I mean, I think that that's one of the most important pieces. The model works because it's case-based. It's like rounds. And so having it be someone who's not involved in the care, or having it someone who is a different involved in the care, not as the clinical provider, then creates sort of this like telephone-like effect, and I don't think it will have the same impact. The training will have the same impact as it does, from being a provider who's listening to how other people are caring for their patients and also getting consultations on how they're caring for their patients. I mean, that's sort of the core of the model, and that's why but I think that we also understand that one of the reasons we're doing this as a separate ECHO series is because we understand that there are constraints. And so I think that we need to sort of, I think that my suggestion is that people fill out the applications and that we work with people to figure out who
Oh, it sounds like we're getting a lot of wind noise.
Uh-oh, somebody just dropped off. So I think that, I also think that it's an opportunity for providers to get some, to do some training. I mean, the providers who participate are very enthusiastic and they love it. So that I think that even for volunteer providers, for an hour a week, if you can find volunteer providers who have that level of enthusiasm, that would also, that would be ideal.
Yeah, I think I'd underscore what Tamara said. For you to fill out the application and propose the providers that seem to make sense for your setting, be they nurses and not physicians, because we are trying to understand who are the providers in the free and charitable clinic setting who could benefit from this intervention.
Well, we have just a couple minutes left, so any other questions from any of the participants? Or comments from any of the other participants? Okay, so with that, I guess we'll just wrap up the webinar, and I want to thank everybody again for joining us today. We're really, really excited about this initiative and um, all of this work that we'll be doing. And so we really look forward to seeing your applications come in. And if there's anything that we can do or any questions you have after the webinar today, please don't hesitate to get in touch with any one of us using the contact information you see here on the slide. Again, the materials you can download from the bottom right-hand corner, or you can access on our website. We're also recording this webinar today, so I will post a link to the recorded version of this webinar to our website as well, so that way you can access it after today's call. So thanks again, everybody. Thanks again to Julie, Leslie, and Tamara for being here, sharing information with everybody, and have a great afternoon.
Thanks, everyone. We look forward to receiving your applications.